Hello, everyone, and welcome to another edition of our Academy of Pediatric Physical Therapy Student New Professional live discussion. Thank you for joining us for our second round of this discussion. We're happy to have you and looking forward to hopefully some good questions. For those of you who haven't joined us before, welcome. Just to go over kind of the format and the purpose of these videos again. Main purpose is just to hold hopefully what will be a monthly discussion with PT students and new professionals who are either interested or work currently in pediatrics, and to just cover a range of topics pertaining to the practice of pediatric physical therapy. So, for example, our first one was on children with complex medical conditions. And then tonight, our discussion will be focused on vestibular conditions in children that pediatric physical therapists might encounter. So the format, how we usually do it, is we just go over a little background information on our topic, and then I go through a short literature review. Obviously not here to cover everything under the sun, but the most pertinent and some of the more recent articles hopefully will be covered. And then I'll give out some resources related to this topic, go over the key points, and then we will close for this evening. The cool thing that hopefully we will be able to work as well is that you are able to send in your comments or questions live while we're doing this chat, so that if you have a question or a comment on any of the things that I talk about tonight, you can send that in using the hashtag PEDSSNP, that's PEDS SNP, to my Twitter account, which again is at NickSellSPT. You can find that on our Facebook page, and hopefully we shouldn't have any trouble accessing that. But, okay, without further ado, we will begin our discussion. So, why, first of all, is this topic important for us to be talking about? Well, I'll go over kind of the prevalence of vestibular and balance disorders in kids in a little bit, but certainly it's something that we might encounter as pediatric physical therapists. It may be something that's a primary diagnosis of a child that we are seeing. It may also be something underlying that is a comorbidity for a child who has another condition, which we'll go over a couple of those later in the literature. There's been some examples of underlying vestibular and balance deficits in children with some specific other primary diagnoses. So another reason for this is just that there's been some recent literature on this, as it's been a topic that hasn't really been studied in depth until recently for pediatrics, in terms of the rehabilitation for these kids with these vestibular concerns. So with that, I will go into some definitions that will be important for us tonight as we're talking. So this is citing an article in 2016 by Banoun titled Balance and Vertigo in Children. And so how the authors describe balance is a motor function that enables a person to control coordinated movements. Any dysfunction of the neural axis that commands this control results in a disturbance of balance, leading to symptoms of dizziness. And so going off of that, the definition of vertigo that these authors use is a sensation of movement that may be rotational or moving forward and can include tilting. May result from abnormalities of the labyrinth system or the central nervous system that spans from the vestibular nerve to the brainstem and cerebellum. So those are important to keep in mind, but when we're talking to families, and especially when we're talking to kids, the language that we use needs to be very specific so that they know what we're talking about without using that degree of language. So how these authors suggest talking to kids about difficulties with balance is, first of all, obtain an accurate history, and this may be difficult just due to kids' vocabulary. So some of the terms that they suggest you can use if you're describing dizziness are spinning, swinging, sliding, or being on the merry-go-round. So kind of connecting playground terms with what we would consider as dizziness or vertigo. Symptoms that we should be on the lookout for in kids with vertigo include nausea, vomiting, pallor, and perspiration, but not loss of consciousness. And then additional historical questions should address head trauma, fever, infections, and a family history of vertigo or migraines. As far as our physical exam of kids with suspected vestibular disorders, these authors suggest that we focus on evaluation of the external and middle ear, an ophthalmologic assessment for signs of nystagmus, and neurological examination of the cranial nerves, cerebellar function, and gait. Additional testing that they recommend includes hearing testing and audiometry, which obviously would require a referral to someone like an audiometrist. Brain imaging such as an MRI is only needed if the history and physical findings suggest an intracranial process. Otherwise, these would not be indicated. As far as what's most common in kids, middle ear disease would be the most common cause of vertigo in children, and that's followed by BPPV. Other causes in kids could include migraine, vestibular neuritis, so something like a bacterial infection, head trauma, Meniere's disease, or cerebellar and brainstem tumors. So all comorbidities and other things within the history that we should be on the lookout for as PTs. So with that as a background, we will get into a discussion of some of the current literature that's out there on this topic. So the first article that we'll be talking about tonight is by Lee et al. From 2016, this year, and it's titled The Epidemiology of Dizziness and Balance Problems in Children in the United States, a Population-Based Study. So the objective of these authors was to study the national prevalence of dizziness and balance problems in U.S. children and explore associated risk factors and patterns of healthcare utilization. So their study design was a multi-stage, nationally representative probability sample of kids. Their N was 10,954, and kids were aged anywhere from 3 to 17 years, so it's a pretty wide sample that we're looking at. And they looked at this based on the 2012 National Health Interview Survey of Children Balance Supplement. So how they went about this is parents were asked if during the past year their child was bothered by symptoms of dizziness and balance problems. And these included vertigo, which was described as motion sensation, lightheadedness or fainting, standing up or walking, frequent falls, or other dizziness and balance problems, as well as clumsiness and poor coordination. Logistic regression was then used to examine associations with sociodemographic information, birth weight, developmental delays, and significant health conditions. So what the authors found is that the prevalence of dizziness and balance problems in U.S. children was 5.3%, so about 1 in 20 kids, and that includes about 3.3 million U.S. children. Females tended to have more problems than males. There was a 5.7% female prevalence versus a 5.0% male prevalence. Non-Hispanic white children had an increased prevalence compared with Hispanic and non-Hispanic black children. Prevalence tended to increase with age from 4.1% for children aged 3 to 5 to 7.5% for children aged 15 to 17. And then even though the majority had symptoms rated as no problem or a small problem, 18.6% had symptoms rated as moderate, big, or very big problems. Overall, 36% of children with dizziness and balance problems were seen by healthcare professionals during the past year, and 29.9% received treatment, so about 1/3. Among children with dizziness and balance problems rated as moderate, big, or very big, 71.6% of these children had seen healthcare professionals, and 62.4% received treatment for dizziness and balance problems. So about 2/3 of those with moderate to severe symptoms saw and were treated for balance and dizziness problems. So the conclusions of these authors were that the risk factors identified provide useful epidemiologic information about dizziness and balance problems in children and will be used in tracking the Healthy People 2020 goal to increase utilization of healthcare services for these children. So I think as pediatric PTs, what we can keep in mind with these findings and these results is just that balance and dizziness problems, while they're not extremely common in kids, they certainly can happen. 5.3% is, again, about 1 in 20 children that are in the U.S., so definitely something that we can be looking out for and something that is potential concern for kids that we may be seeing in physical therapy here in the United States. So, with that, let's move on to our next article. So our next article was by Christie et al. It's from 2014. And the title of this article was Reliability and Diagnostic Accuracy of Clinical Tests of Vestibular Function for Children. So the purpose of this study was to determine the reliability, diagnostic values, and minimal detectable change scores with a 90% confidence interval of pediatric clinical tests of vestibular function. So these authors' methods were their N of 20 children with severe to profound bilateral sensory neural hearing loss, and 23 children with typical development, aged 6 to 12 years, participated. And the list of tests they used include the head thrust test, the Emory Clinical Vestibular Chair Test, the bucket test, dynamic visual acuity, modified clinical test of sensory integration on balance, and sensory organization test. And each of these were completed twice for reliability. Reference standard diagnostic tests were rotary chair and vestibular evoked myogenic potential. And then the authors looked at the reliability, sensitivity, specificity, predictive values, likelihood ratios, and 90% confidence interval scores. So the results, what these authors found was that the reliability for each of these tests ranged from an intraclass correlation coefficient of 0.73 to 0.95, which is fairly high. Sensitivity, specificity, and predictive values, using cutoff scores for each test representing the largest area under the curve, range from 63% to 100%. And then the minimal detectable difference with a 90% confidence interval for the dynamic visual acuity and the modified clinical test of sensory interaction on balance, or the modified SIT-SIB, were 8 optotypes and 16.75 seconds, respectively. And so the conclusions of these authors were that clinical tests can be used accurately to identify children with vestibular hypofunction. Now, what this means for us as students and future PTs, or current new professionals, is that the tests that we have out there for detecting vestibular hypofunction in children can be considered reliable, valid, sensitive, and specific in terms of identifying these deficits in children with vestibular hypofunction. So basically, the tests that we have do a fairly good job of identifying kids with vestibular dysfunction, which is a good thing. Okay, so our next article is by Fay, and this is also from 2016, and the title is Benign Paroxysmal Positional Vertigo, so BPPV, in 2 children, a case series. So this is a smaller study, but still relevant, especially considering that these were 2 kids seen for physical therapy as a result of vestibular issues, even though they may not be the most common. So the purpose of this case report is to present the cases of 2 boys with benign paroxysmal positional vertigo, or BPPV. Key points from the authors: patient A was 11 years old and patient B was 9 years old, and both had complaints of vertigo with position changes, which is something that we would typically expect with a diagnosis of BPPV. Both exhibited left torsion upbeating nystagmus in the left Dix-Hallpike test, and complaints of vertigo with reproduction of their symptoms indicating BPPV, which is the same that we would expect for an adult patient. Both were treated with a left canalith repositioning maneuver and reported decreased incidence of positional vertigo upon reevaluation. Scores on the Dizziness Handicap Inventory and the Visual Analog Scale for dizziness decreased after treatment for one of the boys. So the conclusion of these authors were that benign paroxysmal positional vertigo is considered rare in children. Migraines may also cause vertigo, which we discussed before, and differential diagnosis in these cases was made by performing the Dix-Hallpike test. And so their recommendations for clinical practice are that children with vertigo should be screened for BPPV through use of history taking and the Dix-Hallpike. So again, as PEDS PTs, what's important here for us to remember, BPPV is an uncommon diagnosis in kids, but it can happen. And so if we're hearing things in the history that are suggestive of this, such as what these boys reported in this study, which was vertigo with positional changes. Something like a Dix-Hallpike test can be used to identify BPPV in young children, in this case 9 years old and an 11-year-old, and also through accurate history taking. So that history taking is key in teasing out some of the differences between what might be considered BPPV and some other type of vestibular hypofunction or some other consideration, such as something more serious like a tumor, cerebellar, or brainstem tumor that we discussed earlier. Okay. As long as we don't have any questions or comments yet, I will move on to our next article. So, this next one is by Saxena, Rao, and Kumaran from 2014, and the title of the study is An Analysis of Postural Stability in Children with Cerebral Palsy and Children with Typical Development, an Observational Study. So the purpose of this was to analyze and compare postural stability during static upright standing between children with cerebral palsy and age-matched peers with typical development. The methods these authors used were 45 children with spastic cerebral palsy, 34 with diplegia, and 11 with hemiplegia, and 45 children with typical development, aged 5 to 12 years, were assessed using a posturography device. Postural stability was evaluated under 4 sensory conditions: eyes open on a firm surface, which would be considered more of a visual, using the visual system for balance. Eyes closed on a firm surface, which would be considered more proprioceptive challenge. Eyes open on a foam surface, which again would be considered mostly visual. And then eyes closed on a foam surface, which would be testing the vestibular system specifically. So the results that these authors found were statistically significant differences were obtained between children with spastic diplegic CP and children with typical development under all conditions involving visual and somatosensory or proprioceptive conflicts. But no significant differences were found between children with hemiplegic CP and children with typical development. So the conclusion of these authors was that children with spastic diplegic cerebral palsy have increased postural instability under sensory conditions that involve both visual and somatosensory conflicts. So I think this is great and definitely useful as a pediatric PT or a future clinician, in that it shows us not only are children with cerebral palsy potentially at higher risk for vestibular or in general a balance deficit as compared to peers who are typically developing. We might even expect that, considering our patient presentation and the etiology and manifestation of the cerebral palsy. We may expect balance deficits as a result of secondary impairments as a result of the CP, such as motor or sensory deficits. We may expect that. But what I think this study does a really good job of, and what it provides for us, is that it differentiates children with hemiplegic CP, who they did not show to have significant differences compared to children with typical development in terms of balance, and children with spastic diplegic CP, which did. So we might, in the clinic, take this information and say, if we have a child with spastic diplegic cerebral palsy on our caseload, we may be more apt to expect some of these balance deficits as compared to a child who's considered typically developing, or even a child with hemiplegic CP, who we may screen for balance deficits, but we may not have as high of an expectation that they're going to have as much postural instability as someone who has a diagnosis of spastic plegic CP. So hopefully that will help us in our future practice going forward. Again, just checking, seeing if there's any questions or comments. Don't see any yet, but if you have them, please send them my way. Okay, so our last article then that I have for tonight is by Hallberg, Standring, and Hassan from 2013. And this is a case report of a child with congenital torticollis and saccular dysfunction. So the importance, according to the authors of this, is that this is the first report, to their knowledge, of a child with torticollis due to a saccular dysfunction. So their observation of this child was an 18-month-old infant with torticollis referred for postural imbalance and observed rotary nystagmus. The infant had undergone physical therapy treatment for left torticollis for nearly 15 months. Cervical vestibular evoked myogenic potentials were recorded to assess saccular, which means the inner ear, saccule, which detects vertical acceleration and deceleration of the head, to assess saccular function and caloric stimulation, and positional and rotational testing were performed to evaluate other vestibular receptors. So this child demonstrated abnormal vestibular evoked myogenic potentials with a low amplitude response on the left, which indicated left side saccular dysfunction. The patient's rotary torsional nystagmus suggested positional vertigo, secondary to abnormal saccular function. So the results of this case study were that this patient underwent 1 year of vestibular physical therapy, focusing on saccular function and retraining. 12 months after his original neurologic workup, he underwent repeated myogenic potential, vestibular evoked myogenic potential testing, which demonstrated a normal test. The vestibular evoked myogenic potential responses were present bilaterally with appropriate latencies, with only a 20% amplitude reduction on the left side compared with the previous 69% reduction, and there was no pattern of hypersensitivity to sound stimulation. So the conclusions and relevance, according to these authors: this case highlights that saccular dysfunction should be considered when timely resolution of congenital torticollis is not obtained with physical therapy. Early detection of abnormal saccular function in infants and young children with congenital positional torticollis is necessary to ensure appropriate intervention. Further study needs to be done to confirm our findings. So again, while this was a case report of one patient, it certainly still has relevance and importance for us because as PTs, and especially working in something like an outpatient pediatric setting, congenital muscular torticollis is a common diagnosis that we will encounter or may already be encountering. And while this is typically not due to vestibular concerns or something like a saccular dysfunction, I think this case report does well to keep us on our toes in terms of looking for certain things that may suggest that this is not a typical case of congenital muscular torticollis. So some of the things that jumped out to me in this case report were the fact that this infant, obviously they observed rotary nystagmus with this infant, which would suggest something like a positional vertigo. Even though this patient may not be verbal or verbalizing, that they have dizziness or balance issues or vertigo, this is an objective finding that we can use to say this may be what's going on. Also, the fact that physical therapy had been administered for 15 months without resolution of this infant's symptoms. Eventually, he became a toddler with these symptoms. That should be, at least a yellow flag for us to say there might be something more going on here that I maybe need to look into further. That may not be a typical case of something that I very typically see in kids in my practice. And so just something to keep in mind. Again, torticollis due to a vestibular hypofunction is rare, but it's something that we potentially could encounter in our careers. So something to remember and keep in mind. Okay, so with that, end of our literature review for now. Some resources that may be helpful in the future going forward, just for a quick look at what vestibular disorders look like in children. One of them is the Vestibular Disorders Association. They actually have a section on their website dedicated to pediatric vestibular disorders, and it goes pretty in depth into what we might expect to see and the presentations of children with specific vestibular disorders. So that can be helpful as a clinician if you need a quick check within the clinic or just at home as a resource for you to look at if you're considering that one of your patients may have some vestibular concerns. And then another resource, this is helpful for parents, kids, and teenagers to look at, would be www.kidshealth.org. It does a great job of using patient and family-friendly language to explain some of these balance and dizziness concerns that kids might be having or that parents may be having about their children. It does it in a very nice succinct way that parents and families and patients themselves can go on and see what balance and dizziness looks like in kids, and when to sort of seek services for something that they may be concerned about. So with that, the key points to remember from this discussion and moving forward in treating kids who may have vestibular dysfunctions are dizziness and balance problems are rare, but they certainly do occur in children. Again, going back to our first study, approximately 1 in 20 children in the U.S. have a balance or dizziness problem. Some things to look out for. There's certain groups. We talked about white more than non-Hispanic, Black or Hispanic children have a higher prevalence. Girls tend to have a higher prevalence than boys, and then prevalence tends to increase with age. So teenagers 15 to 19 have a higher incidence than younger children 3 to 5 years old. So something to keep a lookout for. Another thing is just to screen for vestibular hypofunctions in patients with symptoms such as nausea, vomiting, pallor, or perspiration without a loss of consciousness, and histories such as head trauma, fever, infections, and a family history of vertigo or migraines. Any of these commonly associated with dizziness and balance issues, it's a good idea to screen for these when taking your history. Another key point is to work with your team wherever you may be. So that's audiology, neurology, speech, OT, etc., whatever is indicated, in treating the child with vestibular hypofunction, both to determine the root cause and to provide treatment. And then finally, consider comorbidities that may be associated with vestibular hypofunction. So we talked about spastic diplegic cerebral palsy, torticollis, while rare. There's other reports in the literature of developmental coordination disorder being correlated with vestibular and balance deficits in kids. And there may be several more that we haven't touched on here, but just to consider some of the more common co-occurring diagnoses with a vestibular or balance deficit in kids. So with that, if we do not have questions, which I don't currently see any, which is totally fine, feel free to email me personally if you have any questions about our discussion tonight, about our discussions in general, about our last discussion. I welcome your feedback. You can email me at sopsnpsoc@gmail.com. You're also welcome to just post on our Facebook page if you have questions. The Academy of Pediatric Physical Therapy Student and New Professional Subcommittee on Facebook. Our next meeting, our discussion will be planned for early to mid-August. And again, we're open to suggestions on topics. So if anyone out there has something that they're really passionate about or want to learn more about that they'd like to see discussed, or they feel is something that would be helpful for fellow students and new professionals, please send it our way, because we would love to hear from you and talk about what you're interested in. So with that, if no questions, I will close it for tonight, and we will see you next time. Thanks.